Hey, what's up everyone? Welcome back to the Endo channel. To any new souls out there, my name is Denton, and thanks so much for logging on. I'm so happy you're here. Please consider subscribing to help support my channel. Today, I am taking y'all with me to Denton, Texas for my very first endometriosis consultation with a true endo specialist, Dr. Dulemba. So this video is much longer than my typical videos. However, I was going back and forth and debating with myself, do I need to edit it further? But I came to the conclusion, how would I feel if I was on the other end? And I used to be. I had no idea endo specialists even existed. So I feel every woman should have access to this information. It is so helpful. So I hope you enjoy it. Please comment below if you have any questions, and if you are not already following me on Facebook and Instagram, come find me. The links are below in the description box. Here we are. Let's go. Hey everyone. Okay, so we are here in Burleson. I just dropped off the kids Aaron and I did over at their Aunt Charity's. They are going to be hanging out with cousins while I go to Denton. Denton from Burleson is about an hour, so we have another hour to drive. We've been on the road for about 2.5, 3 hours already, but yeah, I'm ready. I'm excited. I'm anxious. Yeah, I have a lot of different emotions running through me simply because with endometriosis, you feel as though you have your case all figured out. You find your groove with it. I've been working so tremendously hard on my fitness, my spiritual, mental health, just all of it. So to be able to have put this surgery off for as long as I have, which is 2 years, January marks 2 years since my last surgery. And the 2 prior to that, I only had 6 months relief in between, and surgeries were soon after. So this is the longest time I've gone, which is really exciting. So yes, I'll keep you posted. Wish me luck. Bye.
All right, now, so how old were you when you started your periods?
I was 12.
Okay, and you're 31, so were they painful then?
Yes, I had my very first surgery when I was 13.
Oh my gosh.
They thought it was my appendix. I could barely walk from pain, and opened me up. Appendix is fine. Ovaries are covered in cyst. It was my first experience.
Wow. All right, so you were 12, you said, right?
Yes.
Okay. Do you ever have PMS?
Yes.
Well, pelvic pain and painful periods.
Yes.
Okay. Loose stools, and I assume you've had a colonoscopy?
Yes.
Okay. And that was normal?
Yes.
How long
That was
ago?
a few years ago.
What about painful intercourse?
Yes.
Okay. Lower back pain with your periods. Okay. All right. You already said your family history is positive. What's fascinating is if you open that brochure, that left flap, you know, that's the main symptoms of endometriosis, you're a yes for all of those.
Yeah.
So even if you had never been diagnosed with endometriosis, you have every single one of them, including the family history of it. And it's so many patients have been diagnosed with IBS that have endometriosis. You know, if it's random loose stools, maybe it's IBS. If it's with your cycles, one disease. By the way, do you ever find yourself bloating after you eat?
I do bloat, yes.
I have a theory on that. I urge you to keep an open mind.
Okay.
That's all I urge.
Sure.
You don't have to agree with it. Just listen to it and then think about it, and then you can believe what you want to believe. But if you won't even take in what I have to say, then that's not helping you either.
Exactly.
Because then you're going to eliminate aspects that might not need to be eliminated. In my opinion, endometriosis is an immune system disease. It appears that women with endometriosis are 7 times more likely to have hypothyroidism. 66% have lots of allergies. They and their families are more likely to have lupus, rheumatoid arthritis, fibromyalgia. 90% have a problem with their bladder, where they pee a lot during the day, they pee a lot at night. There could be microscopic blood in the urine. They think they have a lot of bladder infections. It's called interstitial cystitis. Have you ever heard of it?
I have.
Okay, have you ever been checked for it?
I have not.
With all those surgeries?
To be honest, the only time I heard about that term was through the endo community. Not one doctor has mentioned it. You'd be the first. So I'm happy to be here. Yeah.
I mean, my job is to make you feel as good as I can. So then what is endometriosis? Well, endometriosis is glandular cells similar to the lining of the uterus. It gets where it doesn't belong. There's actually a second cell that goes along with it called a stromal cell. So you actually need both cells to be classified as endometriosis. But we only just talk about the glands, but it's both. And you can have one or the other. You can have stromal cells and you can have glandular cells. But until you have both, most pathologists will not say endometriosis. Those cells can get anywhere. They can be in the muscle of the uterus called adenomyosis. Some of the doctors says that it's a different disease than endometriosis. I'm like, wait. Adeno means glands. Myo is muscle. The word osis means where it doesn't belong. It's still endometriosis. But again, some people think that it's different. I think it's the same. But either way, it's difficult to treat because we can't get to it. Those small dots, if they're in here, it's like in an apple, trying to determine where would a small dot be in that apple. You couldn't tell. You can't just, let me just keep opening the apple, trying to figure out where that small dot is. Symptoms, heavy, irregular, and or painful periods. Okay. Plus, endometriosis can get anywhere on the uterus besides in it, on or in the tubes, on or in the ovaries, on or in the bowel. When I take out an abnormal appearing appendix, 30% have it in the appendix, in their liver, on their diaphragm, in their lungs. It can get, in essence, anywhere. I like to keep this on my desk. It's from about 3 years ago. It's kind of significant, so I keep it here. We did a bowel resection, and this one's on my Facebook page, by the way, but you kind of have to search for it. We took out 6 inches of her bowel and put it back together, but we also did some lymph node dissection. We took out 18 lymph nodes. 3 of 18 lymph nodes positive for endometriosis. There it is, right? So this disease is much worse than I think some of our experts even say that it is. So it can be anywhere. Actually, I know of, she wasn't my patient, but I talked to the mom. She was 16, never had a problem, and I can't recall whether she got the flu vaccine or she got the flu, H1N1. And from that point on, her life is a disaster. Even has endometriosis in her brain, in her lungs, in her brain, just from getting the flu. It changed her immune system. I think this disease does spread. It does get worse over time, and it's a bad disease because people's lives are so interfered with. So next is the controversial part. What makes it grow? What I want to do first is talk about another disease process, because everybody blames estrogen. That's all you hear is estrogen, estrogen, estrogen. When you have a faulty premise to begin with, how can you base any thoughts or treatment options or plans based on that premise? So everybody says estrogen, and that's based from 100 years ago, and that's what's propagated since then. And I challenge doctors to please show me any evidence that you have that it's estrogen. And nobody has. About 15 years ago, there was a huge study done called the WHI, Women's Health Initiative. But they were looking at breast cancer and its relationship to hormones. There were over 30,000 patients in the study. It's just unbelievably huge. And they're still publishing data today based on the study. So they were looking at 3 groups of women in menopause. No hormones, estrogen and progesterone, and estrogen alone, and its relationship to breast cancer. And the progesterone was called medroxyprogesterone, MP. So if you do look the study up, which I urge people to do, you'll see the progesterone is MP, because they don't use the brand names because it's called Provera. And the estrogen is CEE, conjugated equine estrogen, which is horse pee. Premarin. Now, it's one of the most widely used estrogens out there. It's been around for 75 years. I sometimes sit there and think, I wonder what the doctors were thinking of 75 years ago when they went, let's use some horse pee. So the group that took 0 hormones still got a little bit of breast cancer. Not a lot, but a little. And there's 2 reasons for it. The first is, and guess what can happen in menopause, by the way, with endometriosis? Some can grow. Because you'll hear doctors say, oh, we'll just take everything out and you'll be fine. Well, you might have less pain, but that doesn't mean the disease is gone. There's less pain. Okay? So the cells of endometriosis and breast cancer can be so abnormal, you do not need hormones. The second aspect is there are cells other than ovaries that can generate hormones. Your adrenal glands can do that, fat cells, endometriosis cells, and breast cancer cells. So no hormones or no ovaries doesn't mean it's a get out of jail free card. The group that took estrogen and progesterone together had 20% more breast cancer than the 0 hormone group. That's when Katie Couric and Dan Rather came out and said stop hormones. Literally, doctors and patients were panicked. And they just said stop hormones. They didn't say stop estrogen and progesterone. They just said stop hormones. The group that took Premarin by itself, 20% less breast cancer than the 0 hormone group. When you look at it, that's a 40% difference when you add progesterone. Now, in that study, if you had a family history of breast cancer, you didn't get the 20% reduction. It was equal to 0 hormones. So when I look at that in a huge study of 30,000 patients, and the worst that estrogen is by itself is equal to no hormones, but the best is a 20% reduction, to me that's not causing breast cancer. When somebody has breast cancer and they cut it out, they send it to the pathologist, and what do? They check it for estrogen and progesterone receptors because they want to know what's making it grow. Because there will be some that have no hormone receptors. That's what's called a triple negative. They also check for another receptor, but that's called triple negative. Then they're looking to see, is it estrogen, is it progesterone? 65% of the breast cancers are positive for both estrogen and progesterone. Based on that, about 13 years ago, I sat down with some of my smart friends who sadly are retired. But we said, if these diseases somewhat parallel each other, why don't we get estrogen and progesterone receptors on all of our specimens so that we know what's making it grow instead of assuming estrogen? Because if they assumed it was estrogen for breast cancer, there'd be a lot of people dying out there. What I've been doing is gathering estrogen and progesterone receptors for 13 years. And Dr. Vidali's now doing it. And he actually gave me credit.
Nice.
Yeah, he went on Facebook about 2 months ago. And he said, okay, I'm going to get estrogen and progesterone receptors on all of my specimens. And I got to credit Dulemba. Because I've been beating everybody's heads on this and telling patients about it. But I didn't put it online because it's so hard to convince people's thought processes. But as soon as another doctor said, I'm going to do it, then I just jumped right in and said, okay. And plus I wanted to give him information. You can't just order it. You got to do it on every specimen. You can't just do it on one specimen. I want to go through some of these and it'll sort of show a sequence of what might be going on. So here are 5 areas that I cut out on this one patient. One of the 5 areas were positive for estrogen receptors, so 1. 4 of the 5 were positive for progesterone. So in this patient, what might be the worst hormone? Progesterone. One of the specimens had both, 1 had none, and 3 were progesterone only. So in the same patient, different receptors in different areas. Oh, it gets even more interesting. So here's another patient. 1 of the 4 were positive for estrogen, all of them positive for the progesterone. Again, in this patient, worst hormone, progesterone. She did have 1 that had both. Then the next is a 14-year-old. 3 areas we cut out. 2 were positive for estrogen, 1 negative, but all positive for progesterone. Okay, see a little bit of a pattern here? Here's another lady, 1 negative estrogen, all positive for progesterone. And this lady, including diaphragm, all positive for estrogen, all positive for progesterone. What I found over these 13 years is, one, it doesn't matter where they are in their cycle. It doesn't matter whether they're in menopause, whether they're taking artificial hormones, where, their own hormones. But in the younger patients, milder amount of the disease, it seems like the predominant hormone receptors are progesterone. So, as I said, the milder the amount of disease, the earlier the disease, and the younger the patient, I see a predominance of progesterone only. Of course, what does everybody want to do? They want to give you progesterone. 75% of endometriosis is positive for both. I see a lot of patients with advanced disease. So it's almost always in those advanced patients, both estrogen and progesterone receptors. When I look at all of this, I'm like, wait a second, we may not be helping our patients as much as we think. Because ACOG, what does ACOG recommend? Birth control pills. Maybe we're doing more harm. So that's my take on endometriosis. So the next is treatment options. So the first option is do nothing. Probably not a great option. The second option is pain management, wide pain management. I don't fix everybody. I would love to say that I'd fix everybody, and I don't. There's a couple reasons for it. For one, your disease has been there for 19 years, minimum. Okay. That's almost a fifth of a century. The longer a disease is there, not just endometriosis, but any disease, the harder it is to fix. That's not saying we can't fix it. It just gets harder to fix. Plus, there can be issues other than endometriosis that can cause pain. So what I want to do is I want to go through them. Now, the first is, so let's start with infection. Any infection from your appendix, from like a sexually transmitted disease. There's two other infections that I don't really deal with. I don't know a lot about, but I like to at least mention them. One is called SIBO, small intestinal bacterial overgrowth. The next is Lyme's disease. It's fascinating. I have a patient who she had multiple, she had headaches, her joints hurt, and I said, find somebody, go get checked for Lyme's. Well, she got checked, and 3 of her family members were also positive. Then there's the bone, ligament, muscle, tendons. There is a real entity out there called pelvic floor dysfunction. What happens is, especially if patients go to an expert, and then before the expert does surgery, it's endometriosis. Well, if they have symptoms after, well, it can't be endometriosis because I'm an expert. Therefore, it has to be your bone, ligament, muscle, tendons. Mm-hmm. And so they all get sent for physical therapy. Well, some patients do benefit from it. I'm not saying that it can't be that, because you're allowed to have more than one problem, but I just think it's way overused, just as irritable bowel syndrome is overused. The next is the intestines. As I showed you, endometriosis can grow into the bowel itself. So I'm glad that you had a colonoscopy, because that helped decrease that as a potential. Mm-hmm. Plus, it helped eliminate other things like ulcerative colitis, Crohn's disease, diverticulitis, celiac disease. Mm-hmm. I mean, all of those things can contribute to your symptoms. I have a patient who's now 21, but when she was 15, she had a colonoscopy and surgery and had endometriosis and Crohn's disease. Wow. And she's able to actually, because she knows about her Crohn's, distinguish. So almost all of her symptoms, even before the surgery, were related to her intestines. So now that she has that under control, she's certainly doing tremendously better. Sure. But if we didn't have the colonoscopy, we would have never known. All right, then we get to the bladder. But endometriosis and adhesions can be impacting the bladder, causing symptoms. You had 2 vaginal deliveries, not a C-section, right?
Correct.
Okay. Because sometimes with a C-section, the bladder will be stuck to the uterus and the anterior abdominal wall and really cause a lot of pain and symptoms. Mm-hmm. Then we get to nerves. Have you ever heard of phantom pain? Mm-hmm. Yeah. It's not fake. So you say you're walking down the street and you step on a nail, the nerve sends a signal to your brain that it hurts. Well, if you cut somebody's leg off and there's no leg or foot, they still can have a sensation like they're stepping on a nail, because wherever you cut the nerve, it still can send a signal back to your brain that that foot is there stepping on a nail. So if you pretend like this white dot on the wall is endometriosis. And it's hurting because there's a nerve impacted sending a signal to the brain. So the great surgeon comes in and I cut it out. Well, it should be better, right? Because I'm an expert and I cut it out. Well, in a lot of cases, but that nerve where I cut here still could potentially send a signal back that that's there when it's not there. 2 points, one good, one bad. The good point is it's a lot less common than we'd like to say that it is. Say somebody's had an ovary removed and they hurt over there. A lot of doctors say, oh, it must be phantom pain. Well, it can be, but usually there's something going on when they hurt in that area. The bad aspect is we can't treat that as a surgeon. Because even if I cut the nerve here or here or here, it still may send the signal back. So that actually is why pain management comes into play, including medication, injections, nerve stimular implants, acupuncture, biofeedback, anything to help the symptoms if we can't fix the problem. Then we get to the last part of that called adhesions, scar tissue fibrosis, the healing process of the body. I look at it that is as much, if not more, of a problem than endometriosis. And it just fascinates me how little attention is paid to that part of the body. They're like, well, I did surgery and I got rid of all your endometriosis, so you shouldn't have any adhesions. Like, so you've now found a new way for people to heal, so it's not going to stick? You need to be in every surgery. Yeah. So, all right, so the adhesions, things stick together. And there's different types. There's bands of adhesions. And then there's where they're stuck together, and then the surface can just be fibrotic. So it's not normal skin anymore. So like a burn victim. So you can see the skin is different, and then at the edges it might be pulling. So that is what goes on with healing. So if you look at the healing process, the instant you're injured, healing starts. Primary healing all happens in the first week and a half. So everything that I do is based on that week and a half. Because theoretically, if you can keep things from sticking together in that week and a half, then you're past that cascade of events. So that's what I based all my stuff on. So what do I do to try and prevent things from sticking? So the first thing that I do is I want to be accurate, precise. So you want to cut out endometriosis. You want to get it all, as much as you humanly can. But you don't want to take too much normal tissue. So you take a little bit of normal and the disease. There's an entity out there called TPE, total peritoneal excision. Mostly in the UK and in Iceland is where it kind of originated, where for a little bit of endometriosis, they take the entire peritoneum of the pelvis. So they go, well, we get all the endometriosis. I'm like, okay, but you don't get, what about the nose? What about this? And there's maybe different ways of this disease growing, so you might have gotten rid of what was there, but that doesn't mean it will never be there again. But look at all the normal tissue that now has to heal. That can then become part of the healing process, adhesions. So I think their concept is okay, but I think you cause more problems in the long run. The next is I use heated and humidified carbon dioxide. Up until about 5.5 years ago, I was like everybody else, blew up the belly with carbon dioxide, just like you had before, right? Well, have you ever been to Houston in the summer?
Oh, yeah.
Okay. It's like 99 degrees, 100% humidity. Get out of your car, you sweat, but you don't evaporate, right? Mm-hmm. Well, you ever been skiing? Mm-hmm. Okay, you go up in the mountain, your lips crack, fingers crack, skin dries out, because cold air doesn't hold moisture and it pulls the moisture. So if you blow cold air into your abdomen and you're in there for a couple hours, what might happen to the normal areas of the surface of the tissue? Might dry out. If they're using cold carbon dioxide, they might have dried out that tissue, and as it heals, it may stick. There's so many things we have to think about that we don't. We just talk about endometriosis.
Yeah.
You know, oh, just cut out endometriosis, it should be fine. Well, okay. So then the last thing that I offer is what's called a second look surgery. So what we do is we go in laparoscopically with the robot, and then if there's endometriosis, cut it off, scarred tissue, cut it, take the appendix if need be. So we do everything we're supposed to do. Then we go with it back within 3 to 7 days and break apart any adhesions that have formed or reformed, because that's interrupting that healing cascade, that process. So by doing that, it may help. Well, how effective is it? Well, they actually did some studies in the Scandinavian countries, but some of them were done after that week and a half. Horrible results. Everybody got adhesions. When they did it within 3 to 7 days, 70% did, when they went back a third time to look, 70% did not grow or regrow if they interrupted within 3 to 7 days. What I found is that the best timing is actually about 5 days. 3 is too early. Like, what, you want me to do surgery again? I just did it 3 days ago. No. 7 is still good, but it's getting closer to the end. And not everybody is a week and a half. Some people might be 9 days. Somebody could be 8. You're getting really close to that. So it seems like 5 gives the best chance of not having adhesions, even on the second look when you go back in, or decreasing the return. So 70% do not get adhesions. If you interrupt after that 3 to 7 days, 30% do, which is frustrating because those patients have had 2 surgeries a week apart. So when you do all of that, the heat and humidify, the barriers, all that, it might bump it up to maybe 75%. I don't want to go any higher than that, because then patients start to get, if they're desperate, start to go, well, do it, do the second look, do the barrier, do this. And, and I don't want to give a percentage that might not be as high as I want it to be, or the patient wants it to be. Yeah. Now we'll get to my theory. The way the intestines work is through a process called peristalsis. I don't know if but the muscles are set in a certain way so that one part squeezes, the next part squeezes, next part squeezes. It's like squeezing a tube with toothpaste. That's how the intestines move through 30 feet of waste. When you eat, there's a process called mass effect. So all animals have that. So when you eat, it stimulates your intestines to work. Well, I grew up in an all-Italian neighborhood in Pittsburgh. I'm Italian. All of my friends' parents made wine in their basement. My dad didn't, because we owned a bar. And back then it was illegal to make wine and beer in your basement, or make it. No, it was not prohibition. I've had 2 patients ask me that. I'm like, I'm old, but I'm not that old. No, I don't think it was till like the 70s or maybe somewhere in there where they took that prohibition off as far as making wine at home. And they first came out with some little kits. You couldn't make more than like a liter. But back then it was illegal. You had to have a license, and my dad could have lost his license. But we were bad kids growing up. And so what we would do is we would sneak down to my friends' basements where the vats were. We'd take cups, scoop it, drink it, and think we were getting drunk, and we probably weren't. It was probably grape juice, but we were, thinking, So one of the things that I found fascinating is that when the grapes were there fermenting, when we scooped the grapes, bumped the vat, or even the vibration of walking by the vat caused that fermentation for the grapes to bubble. It would have a release. Like, oh my gosh. And it stuck in my mind and didn't think about it for a long, long time. And then I was watching the intestines one time. We were doing surgery and they were peristalsing. And I watched it bloat a little bit. I'm like, oh my gosh. In the large bowel, there's a lot of fermentation going on, especially from starting transverse colon, descending colon, sigmoid colon, and rectum. And I actually saw my theory go in action. It was about 1.5 years ago. I was in Nigeria. And across from me was Miss Tanzania 2001. And she was even taller than you. And she was like this, but she had had endometriosis and even had a bowel resection in the past. But what would happen is every time she would eat, of course she would have pain with it too, so she couldn't really eat, but she would bloat. And I was sitting there and I'm watching and I'm telling her that I think it's adhesions to the large bowel. Because normally the bowel will squeeze and, it will stir it up a little bit and then there'll be some gas and come out. But if the part of the intestines are stuck, and they're trying to squeeze. It's stirring up the fermentation, but it can't squeeze to push it, so it's not going in a nice orderly manner. This stuff has to work double, so some people will get cramping. It eventually will move down because the stuff above it will push it down, but it's stirring up the fermentation more than you would normally see. So we're sitting at dinner, and she's across from me. She has this tight shirt on, and I'm sitting there, and she starts eating, and a little while later she goes, oh, there it goes. And I literally watch her transverse colon peristalse, and as it's peristalsing, it's starting to bloat. By the end of the meal, she looked pregnant. Almost had to carry her out to the car because she was in so much pain. So if you go online, people go, oh, look at my endo belly. Mm-hmm. And they're flat. A little bit later, they're ballooned. And I'm like, how does food cause that bloating, especially 45 minutes to an hour after you eat? Mm-hmm. I just couldn't get it in my mind how endometriosis can do that. You know, endometriosis can cause pain. Endometriosis can cause problems. But how could it be from what you eat cause bloating 45 minutes to an hour later? And that's why I think it's from adhesions to the large bowel. If it hadn't been where I grew up, I would have never thought of it, ever. There's nothing published on it. You can't go and look this up because, you know, if you ever tell it to anybody, they'll think you're an idiot. They'll think I'm more of an idiot for saying it. But again, I might be wrong, but again, it makes sense because I've seen it. Mm-hmm. And I know in the past when patients have had it, and we cut the adhesions, that bloating goes away. Now, if they get adhesions back, it could come back.
Sure.
But again, that's not proof. But to me, it's some evidence in my eyes. Even in spite of all that we do, that's why some patients still need pain management. Next is hormone manipulation. We've already talked about some of it, so that will shorten this portion a little bit. It's not 2.5 hour talk. That's not bad.
I like it. Normally it's like 5 minutes. We're in and out, and they're like,
really?
See you later.
I couldn't have done that.
Yeah.
Couldn't have whipped people in and out. Just could not. It's a passion with me that I want to share things that I think. Notice I didn't say my knowledge.
Things I think.
No, things I think.
He goes, you're probably going to start having symptoms again in 4 months. He goes, that's my guess.
Well, the funny thing is, if you see symptoms within 3 to 6 months, that's adhesions. You see it online, people go to an expert, they go, yeah, I had surgery 3 months ago and I'm hurting again. Whether it's with me or another expert.
Sure.
And I'm like, that's adhesions. And usually it starts off like, you know, and then you feel it, and then by 6 months, you're like, 8 months, you're like, it's back. And then, you know, then you have surgery in a year because you go another 2 to 4 months hurting and like, I can't take this anymore. And I felt good for a while. You want to feel like that again. That's almost always adhesions. Not that there still can't be endometriosis there, but that chronic all the time pain is almost always adhesions. All right, now, so the hormone manipulation. So birth control pills, you know, we're talking about those before. They're great for birth control. Patients should take them every day so they don't have a cycle. There's no medical reason to have a period. And it makes some patients with endometriosis feel better, but it's not treating the disease. Almost everybody, I'd say minimum of 85% of patients that come to my office have been on the pill before. And if it worked, they wouldn't be coming into the office because they've been on the pill. Mm-hmm. And there's side effects with the pill that hardly anybody ever talks about. Little things like heart attacks, strokes, blood clots, death, liver tumors, little things. It fascinates me that they'll talk bad about other drugs, but I'll just take the pill. Okay. Like, I know of 2 17-year-olds in this town, and it's not a huge town, that have died from birth control pills. You know, so when I look at people dying from birth control pills, I don't want to just give it like it's an M&M.
Sure.
You know, I want them to understand, yeah, millions of women take it every day, and they take it without a problem. But if you have it, it's 100%. Just like when we do surgery, there's a problem. Yeah, even though it might be like, you know, 1 out of 1,000, yeah, it's 100% for you.
Yeah.
So, you know, you need to understand that there's things with it. Patients take it. It's a great drug, but it's not fixing the disease at all. In fact, if anything, it's making it grow, although slower than your own ovaries it would do. Then we get to the progesterone-only medication, which we already mentioned about PMS, it's the PMS hormone. What people don't talk about is because there's Depo-Provera. It's a 3-month shot, it's progesterone only, but if you are on the progesterone only for a year, you have the same bone loss as if you're in menopause for a year or on Lupron for a year. But nobody talks about the bone loss with progesterone. And if you notice, I said if you breastfeed for a year, you can have bone loss the same as if you were on Lupron or progesterone. Nobody talks about that. All right, so the progesterone only, there are some people that do well with it. I'm not saying it doesn't help some people, but the majority of people that have it, they bleed, they're cranky, it's just they don't feel good, and it's the second most common receptor number after both. So I'm like, why do I want to give progesterone, especially in the younger patients? Then it's predominantly progesterone. But if you don't have the receptor information, you don't know that. So you think, if I'm giving progesterone, there's no estrogen, we fixed you. It should go away, right? Well, none of these hormones have teeth in them. They're not going to eat the endometriosis. So what are we hoping in some of these circumstances? That your immune system is going to get rid of some of these cells because it doesn't eat the cells. Okay. The next I think is actually a great hormone manipulation. It's very inexpensive. It's a pill that you take twice a day. There is no estrogen. There's no progesterone. You don't have periods. So theoretically, almost all of the endometriosis will not be growing or being stimulated. But nobody likes the side effects.
Okay, what are they?
Shrinking of the breast, deepening of the voice, increase in acne, increase in facial hair, increase in weight, and increase in sexual desire. So it's called danazol, Danacrin. Patients go, no thank you, I'd rather hurt. It's a fascinating process if you don't understand all of it. So it's an option. Okay. She's like, yeah, sure. Give me Lupron before that. There's one called an aromatase inhibitor. Okay. Remember, all the way back we talked about, other cells other than ovaries can make hormones through aromatization. And aromatization goes on in the ovaries, but in tremendous, it's a lot. So this medication can't really affect the ovaries. So they give it to breast cancer patients and endometriosis patients in menopause to stop non-ovarian cells from making hormones. It's called Femara. Letrozole is the generic name. It doesn't make sense to try and give it to somebody whose ovaries are working because you can't suppress ovarian function. So ACOG, in all of their wonderful wisdom from the experts that they talked to, said, okay, well, why don't we try and start treating our endometriosis patients with their ovaries working with Femara, but we'll shut down the ovaries by giving them birth control pills or progesterone to suppress the ovaries. So it's like, wait, so you're going to give hormones to stop non-ovarian cells from making hormones? Doesn't make sense. But that is one of ACOG's recommendations. Yeah, it doesn't make sense to me, but people, they might feel better, but it's not helping the disease process. All right, then we get to Lupron. Of course, the side effects you have: hot flashes, headaches, night sweats, mood swings, hair loss. But if you have estrogen and progesterone receptors, then say you have no estrogen receptors, it's all progesterone. I wouldn't want to give you progesterone, plus you get PMS. I would give you estrogen. If you have both, which of the two hormones would I give you to help your symptoms? Your hot flashes, headaches, night sweats. I'd give you estrogen because it's not PMS and it's only half of the hormones. So out of the two hormones that are there, I would rather give you something that we normally give to people in menopause, estrogen, versus trying to avoid it if I have the receptor information. So again, it doesn't fix the disease by having the receptor information. It just might help you in making decisions afterward. The last hormonal aspect is the Mirena IUD. IUDs are great for birth control. They are better than a tubal. And it's not permanent, although it used to be 5 years. Now this is up to 7 years that you can keep it in. They found out that 30 to 40% of the patients that they put this in, their bleeding stopped. 60 to 70% still bleed, but 30 to 40% did not bleed. they've now convinced doctors this is a treatment for endometriosis because they're not bleeding. Oh, I fixed your endometriosis. And I'm like, wait, what do you think you're doing out here?
Yeah.
Nothing. In Europe, they do call it the coil. And if you have endometriosis there, almost everybody gets the Mirena IUD. It's fascinating. Like, it's not treating anything. You're just not bleeding in 30 to 40% of the cases. But there are an occasional patient that feels better with it. Now, if somebody doesn't want the IUD and they want to stop their bleeding, in 75% of the cases, one of the things they can do is they can actually burn the lining of the uterus, and it's called an endometrial ablation. Not endometriosis, endometrial. So they burn the lining and 75% don't bleed. So there are people that have it done and they don't have any more pain because their periods, they're not bleeding, and therefore they do improve. It's not fixing anything, it's just helping one of the symptoms. Okay. So the next is imaging. There's 3 ways to image the pelvis, is CT scan, MRI, and the ultrasound. The least informative for the pelvis is a CT scan. Of course, you go to the emergency room, they do a CT scan.
Yes.
For the abdomen and the chest, CT scan is great. Pelvis, not so great. But everybody, they have a CT scan person there all the time. MRI, they might not. What's more accurate and precise is the MRI of the pelvis. It's going to give you a lot more information. CT and the MRI is that it's a snapshot. It just takes a picture. It's not going to tell you anything other than if there's something abnormal, like a large mass, or the adenomyosis, or the thickness of the lining of the uterus, or an ovarian mass, or something, or a blockage in the intestines. I mean, that's the information it's going to give you. The ultrasound can give you some of that same information, but it also can see adenomyosis and can tell us what hurts, what's going on in your pelvis. And neither of the two, the MRI or the CT scan, can do that. So, to me, the ultrasound also is more informative than my pelvic exam. Your left tube and ovary are gone?
Yes, my left ovary is gone.
And what's fascinating is that's where most of your pain is. Now, so it's in its normal position called anteverted. So there can be a retroverted, there can be different positions, but that's just a normal position. It's extremely tender in the midline. She has 3 X's on here. X equals pain. Mm-hmm. Okay. And then she did see some mild adenomyosis. So she has it with these little dots on here. And if you recall, adenomyosis is endometriosis in the muscle. Now, she may not have actually seen the cells. I love World War II movies, and you look for submarines. So you send an ultrasound, sound wave through the water. You have a certain density for the water, so it doesn't recognize that. When it hits something of a different density, it changes the sound waves. The muscle of the uterus is a certain density, and it's one of the only organs we can do this because it's, solid muscle. So you put the density to equal that, so it doesn't really recognize it. And when it hits a different density, like a gland, it changes the sound wave. So she saw a streaking effect and mild heterogeneous effect. So it's more than likely adenomyosis. Okay. But severe pain. Then she looked over at the right ovary. It's a little bit normal than a normal ovary, but that's not unusual because it's taking effect for both ovaries. Mm-hmm. So you sometimes see one increase in size. Good blood flow to the ovary. That right ovary appears not only totally stuck, fixed into position is what she described it, but probably to the uterus itself. Okay. And there's moderate tenderness on that side. Then she did look at that left side, and of course it's surgically absent, and there's 3+ tenderness on that side. And it says, she wrote, contents appear fixed, so your intestines are probably stuck over on that side. All right, because a lot of people go, well, my ovaries aren't there, why am I hurting? I'm like, you'd be shocked at how often I see this. Shocked. So her overall conclusion is certainly history of endometriosis, pelvic pain, underneath your left breast, arm, and leg. Oh, so you had stuff on the left diaphragm, or was it the right?
The left.
Which is really unusual.
Yes.
Most of the time you're going to see it on the right.
That's what I heard, yeah. But it was indeed on my left side.
There was one patient who, again, the majority of it we see it is on the right. And when I went back on her second look, you still look everywhere, and I looked up because we're looking for adhesions, and there was some on her left diaphragm because the ribs are curved. And when I looked before, it was like behind the curve. So when I looked, I didn't see it. And I'm like, oh my gosh. And then this time it was a little bit of a different position. And I'm like, I would have missed that on the left diaphragm. So even though I looked, I didn't see it the first time. And there was some there the second time. So in comparison to the right, it's dramatically a lot less on that left side. Same thing with endometriosis in the lungs. You see it predominantly on the right side. So, and that's why, Doctor, I think that there is a spreading aspect of it, because if it was deposited while you were inside your mom, it would be random throughout, and whereas to me the spreading would seem to be more favoring this side. So suspected adhesions, and the right ovary appears to be adhered to the uterus. So this didn't fix anything, but it gave me a lot of information what's going on in your pelvis. Certainly much better than a pelvic exam. Now, so the last part is surgery. And what I like to do is tell you about my background and then compare standard laparoscopy to robot laparoscopy, and then what we do on the inside. Okay. Now, so as I had mentioned, I was kind of a bad boy growing up. I flunked English and general math in high school. I don't know if you know what general math is. That's add, subtract, multiply. I flunked that. So I went away to military school, then went into college, but I got kicked out of college. After 4 years of, guys, I'm sorry. I kind of let loose a little bit. 1967, 68, kind of a little wilder time. But then right in the middle of Vietnam, I'm like, oh my gosh, I can't go through the jungle. I can't sleep in the tent. There's bugs out there. What, are you kidding me? So I went in the Army and I learned to fly helicopters. Went to Vietnam and then came back, and I was a flight instructor in Mineral Wells, as I had mentioned. And then I got my degree. I went to Tarrant County Junior College, TCJC, Northeast Campus, Southwest Campus. I mean, it was, I actually did very well. Then I got my degree from an aeronautical university because I wanted to fly. I love aviation. But the fuel crisis hit just as I graduated. So I moved to Pittsburgh. I was a bartender at my dad's bar, then got a job as a pharmaceutical sales rep because I thought you had to be smart to be a doctor till I called on them. Like, I can do this. Nobody in my family had a college degree. I was the first one. You just grew up in the blue-collar Italian neighborhood. You either ran numbers or had a bar. I mean, one of the two. There weren't a lot of options there. So it was kind of a little bit of a breakout, and went back, did my pre-med at Pitt. Then I got into the University of Pennsylvania, Ivy League med school. I'm like, holy crap, what am I doing here? But I was 30. I was actually the oldest guy in my class, and it was kind of fun because I sort of stabilized some of them. They were panicked, like I might fail. I said, yeah, but you're still alive. So we had fun, and I was the class clown, as you could probably tell. There's a picture of me mooning in my yearbook, and so I'm still the class clown. And but then I finished, went to Pittsburgh, did my residency there, 2 blocks from my mom's house. I knew everybody in the neighborhood. And then came down here when I finished my training, and I've been down here ever since. But once I came out, I did some OB, but I loved. So for the first 20 years, I did standard laparoscopy. Loved it. But had about 3,600 endometriosis cases. It was what I loved. And about 11 years ago, the robot people came up to me and they said, why don't you try the robot? I said, oh, I love the technology, but I don't really need it. They said, well, you'll be able to suture with it. I said, I can suture laparoscopically. They said, well, give us your open cases. I said, I don't have any open cases. They said, well, just try it. And I'm like, just like every other doctor, rolled my eyes. And once I sat down, I'm like, oh my gosh, so much better. For one, to start with, a robot has a console with hand controls and foot pedals. Helicopter has hand controls and foot pedals.
Cool.
I'm rolling in hot on the Viet Cong. I'm flashing back. I'm like, I'm 21 again. Like, oh. I have about over 1,700 endometriosis cases with the robot. There's probably a few doctors that might have more robotic cases, but there's nobody that has more endometriosis robotic cases than I do, because I'm 100% robot. And there's some doctors that will only do the hard cases with the robot. I'm like, no, hard or easy, I'm 100% robot. And it's just like anything, when your muscle memory, when you do the exact same thing all the time, is better. That's the background. So now let's compare standard laparoscopy to robot laparoscopy. Why do I do it? Well, for one, standard laparoscopy is two-dimensional. It's 2D. You can see quite a bit, but it's two-dimensional. Mine's 3D. And if you don't think 3D is important, drive home with one eye. You're better with two. Now, you can get really good with one eye. Our vision is magnified 10 times. You can magnify standard laparoscopy, but they're holding the camera. And if you have a small imperceptible movement, even 1/5 of an inch, 10 times magnification is 2 inches.
Yeah.
So if you think you're not moving at all, the TV screen's moving like this. And you could be accurate, precise, but if you're cutting around the bowel, then you're a little less accurate, precise when it's moving. So 3D, 10 times magnification versus 2D. Then the surgeon is standing next to the patient, laparoscopically. And every patient is different. You have tall, short, anywhere in between. So your arms are always in different positions. And mine, I'm always in the exact same position as memory seat. So I just push, and all my instruments, the foot pedals, everything, armrests all go to the same spot. And mine's padded, so I'm just sitting relaxed like this. Mm-hmm. So just like you said, you were pacing. If you were standing with some of your arms outstretched for the last 2.5 hours, you'd be more fatigued than me sitting here like this.
Absolutely.
Right?
Yeah.
I mean, that's just the human nature. Mm-hmm. And the more fatigued we get, the less accurate and precise we become. So there's less fatigue, surgeon fatigue. Then the instruments laparoscopically are straight. They can reach different areas. They can kind of torque and come up and torque back this way or come in this way to get to there. So there's you reach the same areas I reach, but mine have elbow and wrist action, 520 degrees of rotation of the wrist and elbow. So it's like putting my hands in there. Then the instrument movements laparoscopically are opposite movements. It's like a seesaw. So in other words, on a seesaw, when one person goes down, the other person goes up. So on the outside, where your hand is holding the instrument, if you move it this way, the tip on the inside goes the opposite way. Mm-hmm. Mine, if I go to the right, it goes to the right. That's called an intuitive movement versus counterintuitive movement. Mm-hmm. Then I can scale my movements. In other words, if I move an inch, the tip moves an inch. Or I can scale it back. If I move an inch, it moves 1/5 of an inch. So when you compare all those, what sounds like or seems like it might be more accurate and precise? The robot or the standard laparoscopy? Without a doubt, the robot. The problem is the doctors that don't do robot will never say that. Because if they said, well, I do standard laparoscopy, but yes, the robot is more accurate and precise, then patients are going to go, let's see, 2 experts? I'm going to the robot.
Exactly.
Right.
Yeah.
So if you go online, they go, it's just a tool. It's just a tool. Mm-hmm. You need to go to the expert surgeon. Yeah, it's just a tool, but it makes you, this accurate surgeon, more accurate. Mm-hmm. But the problem is, say these guys said, you know what, Dulemba's right. I'm going to convert. Do you want to be their first patient? No. Because it takes a while to get your skill level up to where it is laparoscopically. And they're in their comfort zone, so they don't want to change. Plus, if they've got 3,000 or 4,000 cases laparoscopically, and I've got 1,700, they get asked to speak, okay? If they start doing the robot and they've got 30 cases and I've got 1,700, who are they going to ask to speak? Mm-hmm. Me. Yeah. So there's a lot of ego involved in all of this. Now, that doesn't mean everything's perfect. Doesn't mean that we are the best in the world. I think I am, but besides that, we can still have complications. We can have anything that you can have on a standard laparoscopy, an open case, any of that. There are some negatives to it though. Initially, you lose some tactile sense because the patient's over there and I'm at a console. But you develop a visual tactile sense because we can, very quickly actually, because you can actually take sutures, they're called 8-0, which is thinner than a hair. And when you're trying to tie it, most of the time you can almost not see it with your eyesight. You have to have magnified to see it. And I taught somebody, it was actually a doctor's wife from the UK, she was a nurse, to tie and suture overcooked ziti, because we were pretending like it was the ureter, the tube from the kidney, and I overcooked it on purpose so that it would be very, you could cut right through it very easily on 8-0. Okay, so that's thinner than a hair. She was able, in 20 minutes, first couple times she wasn't able to do it, but she was able to put it in there and tie a knot and not damage the overcooked ziti and not break the stitch. She developed a visual tactile sense. You just looked at things. And when you do it enough now, I can even tell when my assistant is there, if I'm mad at him, I go like this, he goes, oh! Yeah, because I knew my arm was hitting him. And I'm in here, So you develop a tactile sense, a visual. And then, of course, some of the guys will yell and say, yeah, but you won't be able to feel a mass in the vagina. I'm like, I'm not glued to my seat. If you're standing next to the patient, you take your hand and you can put it in the vagina, right? Because you put a glove on and do it, yeah. Well, what's to prevent me from getting up from my chair, putting the glove on and doing the same thing? So, and of course the incisions are a little bit higher.
Oh, they are? Okay.
Yes. The laparoscopic incisions are usually lower down, more like a bikini there in the belly button. We use the same belly button, but our 2 incisions are lateral to the belly button.
Okay.
And then our assistant port is higher up.
Okay.
The ones that they use laparoscopically are 5 millimeters. 25 millimeters is an inch. These 2 are 8 millimeters.
Okay.
But everybody goes, well, they're bigger. I'm like, well, 3 millimeters.
Yeah.
Now, the assistant port is bigger because that's where we take out some specimens and stuff like that and put needles down. So it's usually 12 millimeters.
Okay.
So it's almost half an inch versus the 1/5 of an inch or an 1/8 of an inch.
Okay.
It's a little bit bigger. That's the difference between the robot and standard laparoscopy. So once we get in there, if there's endometriosis, we cut it out. If there's scar tissue, we cut it out. That's adhesions, we cut it out. If the appendix is abnormal, we take it. We try and address anything that's in there causing pain. Now, the one thing we can't address is the uterus with the adenomyosis. So we offer to some patients what's called a PSN, pre-sacral neurectomy. That's the nerve that goes to the uterus, and we cut that. And about 50 to 60% of patients where we cut the nerve, they don't have uterine pain as much or at all with their uterus when they're having a cycle. But in about 10% of the patients, it's the same nerve that goes to the bladder and the bowel. And some patients might have chronic
Hey guys, thanks for
urination,
watching. If you liked this
chronic
video,
constipation.
please give it a
That's
thumbs up
the PSN.
and subscribe so you never miss a bit with Britt. We'll see you next time.
It's done the exact same way with